Welcome to Health Systems CIO's interview with Dr. Michael Weiss, Associate CMIO with Memorial Healthcare System and Assistant Medical Director for Pediatric Emergency Medicine at Joe DiMaggio's Children's Hospital. I'm Anthony Guerra, founder and editor-in-chief. Dr. Weiss, thanks for joining me today.
Anthony, thank you for the opportunity to speak to you.
You got it. All right, you want to start off by telling me a little bit about your organization and your role?
So we are speaking. You're in New Jersey, and I'm in sunny South Florida, and hopefully it will not flood today. So I am in a healthcare system in Broward County, which is very close, which is Fort Lauderdale area, just north of Miami. We are 6/7, depending on how you count licenses, hospitals, and one children's hospital, and then 10 emergency departments, plus ambulatory care facilities and professional group.
All right, excellent. So you wrote a very interesting post that caught my eye and wanted to discuss it more. So it's called the Rogue Note Initiative. Um, Tell me a little bit about this. Obviously, I have a lot of more detailed questions, but overall about this initiative and the problem it was trying to solve.
So the Rogue Note Initiative, and actually I love the title, and
Me
it's both
too.
tongue in cheek. One of the aspects of the electronic health record and one of the aspects of Epic and provider satisfaction and burnout is the ability to customize. And if I look back on my Epic journey and our time since implementation, one of our biggest challenges and satisfactions have been associated with the ability to customize our clinical documentation. My main area is the emergency department, and I serve as ACMIO for both pediatrics and adults, about 450,000 visits a year. And we've invested heavily in dynamic documentation. I have a rule that I speak to, which is, and I talk to this with my other medical directors, is don't ever ask me to remember a smart phrase. I'm in the middle of code. Ask me to remember a dot phrase isn't the best use of my cognitive solutions. And so have spent enormous amounts of time using dynamic documentation, using the discrete data within the electronic health record to drive our documentation. I'm an emergency department, so you can think of the various aspects of things that we need to document, both from a quality, safety, billing perspective. So, Joint Commission is very heavily into suicide risk assessment, suicide risk scores. Well, we have very clear clinical documentation using the Columbia suicide screening that this is a patient who is moderate and high risk for suicidality. Well, all this dynamic documentation doesn't work if a provider has their homegrown note template. And we have a couple of templates that we use that are heavily into the dynamic documentation. And I think my last time I looked at it, or before my Rogue Note initiative, it was about 92% of the providers were using that note template. But you have those stubborn 8%. And physicians are easygoing, not opinionated, easy to change their behavior.
Of course.
And those 8% were causing 85% of the problems. And it was driving my compliance people and my medical directors nuts, to the point there was discussion, can we turn off the ability to customize so no one could do their individual smart phrases, et cetera, et cetera. I call that the nuclear option. And there are always a few nuclear options within an electronic health record, and you've got to be really careful when you utilize them. And I thought turning off the ability to customize would be an incredible dissatisfier, decrease our efficiency, increased burnout and frustration. And I'm thinking back to some of my providers, and I can imagine their reactions to that. So instead of doing that, went through all our dynamic documentation and identified where within our progress note they all lived. I assigned them very specific data points and then built the data points into an alert. And so it's okay for you to use your own homegrown templates, but I need you to have these links in there because otherwise we're going to miss things. And I think the results speak for themselves. And this was also one of the advantages of building it this way was in real time, we knew who was not using our dynamic documentation, and we were able to intervene at the elbow. So rather than waiting 2 or 3 months until compliance came back to us and said, we have a problem here. And if we're waiting for chart reviews months later, then we're not effectively utilizing our information to help change workflows and help the providers succeed.
Are, are you all right? Wow, that's great. That's awesome. Tell me more about this term dynamic documentation. What exactly does that refer to?
Within the electronic health record, there's always going to be data points, right? So, and there are very specific data points that are more reliable than others. I always say don't rely on human being interactions because we're going to screw it up. But, lab reactions, they're discrete data points that I can build my documentation off of in a highly reliable way. And so depending on the situation, I can insert documentation requirements in front of the provider, not using pop-up alerts, not using manual chart reviews, and it files into their workflows so that they naturally need to do it.
Okay.
Actually, I have an article that I published a couple of years ago, which was associated with the heart score. Again, my background is pediatric emergency medicine, but for some reason they wanted me to work on the adult heart score. So, and that's true. And that often happens to me. So the adult heart score is a risk stratification tool associated with risk of a serious cardiac event after discharge from the hospital. And it was one of our quality metrics that we wanted to document it effectively. And for a couple of years prior to being asked to help with the project, it was always, okay, guys, if you have undifferentiated chest pain, you got to put in this dot phrase, and then you have to put in the risk score. And when they finally asked me for the help, it didn't really make sense. There are 10 ICD-10 diagnoses associated with the need for a heart score, along with an EKG, which is an order, and along with a troponin. So I took those data points and very simply, if those three things come true, then the heart score becomes hard stopped in your note and you have to place it. We went from about 40% compliance to about 85% compliance in 2 months.
Mm-hmm.
So it's using the data to drive discrete documentation.
Got it. Got it. All right. So, and I've had this. I had a great discussion with another physician, Epic physician builder, at another health system, Dr. John Lee, and we talked a lot about this idea of standardization versus customization in Epic. The term foundation is the one that's used, right, for the
Mhm.
standard Epic build. Uh, but it's interesting that they have, before you did what you did, and I want to get more into some of the technical issues of you creating the sort of alert system you created. which is very interesting. But there it sounds like there's a tremendous amount of customization that can be done by physicians if you don't do anything to curb it too much. Is the
Right.
ultimate message of what you're saying, and others have said that. Um, and we're finding that. I wonder if the point has been made that AI is bringing a lot of data issues to the forefront because we're obviously AI is acting on data. If we want to take advantage of it to drive insights, it's going to leverage underlying data. If that data is not standardized and it's kind of messy, the AI is not going to work as well. So the point Dr. Lee made, and that I would assume you agree with, is that this is a very delicate balance. You're trying to manage burnout, you're trying to give freedom to physicians to do things the way they want, but there's such a cost to that on the back end, not only compliance, but now for AI output, that it's got to be curbed. And it seems like that's what you're doing. It seems like that's a phase we're in as an industry, that of curbing previously granted customizations with good that were given with good reason in order to reap the upside of the AI technologies we want to act upon the data today. I'd like your thoughts on that.
So, listen, this is a fascinating time to be looking at analytics and how AI will and will not change our workflows and our abilities. We are live on DAX right now in my healthcare system and preparing the other pieces of the Epic uh, suite of AI. Matter of fact, I think we go through an upgrade in a month, and so that will be rolled out to some of the clinical providers at that point. When working with Epic, you have to respect foundation and understand where foundation is. And if you're going to deviate from foundation, it has to be for a very clear, concise reason. We went live really before foundation was a um, well-versed option. And so there are data points that we have that predate foundation. And then we're left with a very difficult challenge, which is, do we revert to foundation? Do we do a refuel project? Or do we continue with our historical data points? Within the clinical documentation, this type of build enhances AI.
Hmm.
So rather than having non-discrete data associated with a patient's suicide risk, patient's heart scores, you can actually drive the provider to the foundation system data points. And the fluff in between doesn't matter as much,
Hmm.
right? So I think there's possibilities on both sides. I read John's article
Oh,
um,
good.
about the challenges and the futures,
Yeah, yeah,
and
he's a great thought leader. Go ahead.
um, and actually I met John briefly at UGM this year,
Hmm.
and the next 2 to 5 years will be fascinating, and how the AI integrates with systems that are have a much longer history on Epic versus a new system. But in the end, even with the AI, we're still going to need the data points to drive the providers. And depending on the interface, depending on how effective it is, like what is the current effectiveness of disruptive OPAs or decision support within a healthcare system. Most healthcare systems are happy with 25-30% success rate, right? And
When
so,
you say success, tell me what you mean again by
well,
success.
so if I give a provider an alert that we expect them to act upon,
Right.
right? And AI is going to proliferate these alerts. And so it is going to proliferate the disruption to the provider's workflow, which can have a positive effect if it's built well and the interface works well. But if it's disruptive and not built well, then the providers may just ignore it.
Right. Right. So driving the providers, we've got this idea of working towards foundation for perhaps for the purposes of AI output. You also mentioned previously the idea of compliance, that there's compliance issues of
Mhm.
too much customization. That was one of the things you were talking about we don't want to have the compliance people find this stuff 2 months down the road. That's not a great workflow. So there's compliance issues in addition to sort of AI optimization issues, right? There's a lot of reasons to get this stuff straightened out and to find the right balance, right? Because as you said, going straight to foundation, taking away all customization is the nuclear option, is not what you're thinking or what you're working towards. You have decided that is not a way to go, even though that could solve a lot of problems. But that's not the way to go because there's too much downside, right?
Correct.
Yeah. So
So
many, go ahead. Go ahead.
yeah, so pieces of foundation are brilliant. I sat on the pediatric ER board, and so I've seen foundation grow and develop over the years. But there are pieces that are missing, and if you stick with foundation, then not all the solutions and resources to help the patient and the provider are going to be there.
Let's talk about going, this idea of this sort of rework, and I don't know the exact proper term for it, but it's a decision point that you're facing, which is, do we go back and build back towards foundation, which sounds like a very big deal and extremely disruptive and a lot of work. And do I have that correct?
Yeah,
Is that a huge decision point you're faced with?
Epic calls it refuel. Uh,
Refuel.
I I'm lucky. I don't make that decision.
I'm sure you
Um,
have a recommendation.
so I do have recommendations, and I think there are different ways of doing refuels. There's different ways of going back to foundation, and my Epic TSs and colleagues can probably speak to it to no end. But every time you're looking to upgrade, every time you're looking at your processes, I always go back to foundation to see what they have. I'm always keeping an eye on foundation. I'm always keeping an eye on what other institutions are doing and how they are progressing. So the better we get back to foundation, the more powerful Cosmos is, and that helps normalize data and gives us insights into how other healthcare systems are functioning, and also on the patient.
Is there any it just popped into my head. I don't know if this is kind of an issue or a dynamic of what I would think of as chasing foundation, meaning we want to foundation is a thing, but I assume it's dynamic to some degree. It's not written in time for all time, written in stone. Foundation will change. I mean, as a health system, do you have to watch and stay in lockstep with foundation? And does it ever feel like they're moving the cheese or moving the ball? Or is that not an accurate thing that happens?
I think every electronic health record moves the ball,
Uh-huh.
right? Because if you look back on functionality over the years, and so I'm about 15 years into my Epic experience, and first of all, if I knew then what I know now, some of my thoughts would have and my build would have changed.
Mm,
But at the same point, some of the stuff wasn't functionality. And so if you have to build something as not functionality and then they bring it forward with functionality, sometimes you are left with the quandary of whether you, again, go back and rebuild, reintegrate. And this is true throughout the electronic health record and is not agnostic. And it's agnostic to which one. As they evolve, you are going to have some of your homegrown customization, right? But as the functionality grows, you have to make the critical decision of whether you have the resources to do the optimization because IT budgets aren't getting bigger. right?
Yeah, yeah, absolutely. You have that dynamic of your
Compute.
core vendor not having an offering in a particular area, and you're faced with a couple of choices. You can either build that, you can wait and do nothing, but then you maybe not are satisfying your users as much as you could. You could build something homegrown, as you mentioned, or you could buy. We saw that a lot in the ambient AI space right now, right? That's
Right.
exactly what's
Absolutely.
going on right now. So Epic announced, there's companies that got very big over the last 3 years
Mhm.
and a lot of customers, raised a lot of money. Epic announces, hey, we're going to do that. And man, ripples through the marketplace, huge ripples. People deciding, do we want to keep on this third party product? Or do we want to, is Epic's product ready? Or do we want to wait a little bit? What do we want to do? Most people that I talk to, a lot of people, they'll just tell you if Epic's good and it's ready, it's what we're doing. That's why we're on the platform. Uh, so I don't know. What are you? And this is what we're talking about right now. What are your thoughts?
Um, w- Very hesitant right now to implement AI, which is not tightly integrated with Epic, depending on the workflow.
Hmm.
So, listen, I'm a physician. Clinical documentation is the bane of my existence, and because we all love to sit down and write notes. There are a few AI options that are integrated into Epic, and they're adding more. But the entire concept of not having your AI integrated directly into the patient, I find to be a at-risk model.
Hmm.
So if I can't use my device to open the patient's chart and in the AI, it goes directly into the chart, but instead is being relied on for copy and paste. I
Mm,
I've been down that road,
right.
um, and someone's going to copy and paste into the wrong chart,
Oh boy. Yeah.
right? And so the tighter certain products are with Epic and being able to do the documentation directly into the electronic health record, the better that those AI products will survive. Now, AI is fascinating, right?
Mm,
And how can we use it? And where best to use it within the clinical experience, the patient experience, the provider experience is, and you're seeing everything pop up over and over with little case scenarios. And I was, as Epic's going to offer their suites of product, but there will always be something that they're missing,
hmm.
right?
Hmm.
And I saw a demonstration of a really nice AI product. It did a really good job on the scribe basis. It didn't go directly into Epic, but it also listened to the patient and you, and it graded the provider and gave the provider feedback on how better to talk to the patient, right? I
Hmm.
think Stanford has a AI product that they are working on that helps residents communicate.
Hmm.
And listen, it's 2 o'clock in the morning. Sometimes you listen to the residents calling consults to attendings, and at 2 o'clock in the morning, you want to be really precise. There's no courtesy phone call at 2 o'clock in the morning, right?
Oh, that's
And
great.
so, using AI to help train us on communication,
Hmm.
using AI to um, help the provider hone in on the actual question they want from the subspecialist. One of my roles as an ER doc is to protect my subspecialists, right? I don't want to be calling everybody at 3 o'clock in the morning because I have a minor question. I want to call them when I have actionable things that is going to directly affect the patient and is going to change the clinical decision making. But at 2 o'clock in the morning, you better be really concise.
Yeah, I mean that's brilliant. That's brilliant stuff. I love the concept, protect my subspecialist. That whole thing is fantastic. We could talk about that for an hour. I want to go back to something else that fascinates me, and I think that maybe people need to understand a little better. I just happen to be very sensitive and of this issue. It's this idea of cognitive load, and the sensitivity to it. And I would say that you need a absolute hypersensitivity to it if you're in this field. You obviously do the work, so as someone in the trenches doing that work at 2 in the morning with a crowded emergency department, and you like you said, I don't want to remember smart phrases. I don't, or I think you're saying, what you're saying is, I don't want to have to remember something obscure that you think is going to make my life easier. So if I say the correct phrase the right way, it makes my life easier. But you want me to remember 50 of them, and
Mhm.
right, and if I say it a little bit wrong, it doesn't work. These kind of things. This idea of cognitive load is you can't, and you tell me if I'm wrong, you cannot overstate that, and you cannot overstate how it's like a feather, right? If you're putting a feather of cognitive load on me that I feel is unwarranted, you failed. Like that's how hypersensitive you have. You want me to look in the left side of the screen, and I'm used to looking in the right side or whatever. Maybe, I'm overstating it, but I just think that that's such a massive issue, which speaks to all this in the workflow stuff. It's got to be in the workflow. And maybe what you think is not a big deal, Mr. Application Provider, or somebody who doesn't do the work, you think it's not a big deal, but I know it's a big deal. So I'd like some more of your thoughts on this idea of the sensitivity of the folks in your line of work to cognitive load.
So cognitive load theory is a fascinating conversation. And if you actually look at cognitive load by medical specialty, emergency medicine is one of the highest, if not the highest. The number of critical decisions we're making on a minute to minute basis is astronomical, and it's compounding every year. It's not like it's getting easier. And a lot of my design in clinical documentation, orderings, disposition, follow-up, consults is to help the provider at the bedside so that they're not trying to remember dot this or this order set. And so trying to integrate everything together. And actually, there are times when I integrate my order sets into my clinical documentation so that they are more likely to succeed. But you have to really click on the button. And then, don't underestimate the value of a well-placed single button click.
Mm,
So, my current project right now, one of my current projects right now, and is the patient's leaving the emergency department. Where should they go? And how to help the patient in their healthcare journey.
hmm
Now, in a perfect world, everyone has openings in their clinic. We have lots of subspecialists who are waiting to see the patient. We don't have to deal with managed care, authorizations. Everybody has insurance. So I practice down in South Florida. We have different healthcare systems to help those who don't have coverage.
hmm
We have patients who come from all over the world. And as an ER doctor, trying to explain the nuance of how to get a patient who lives in an opposing county, who doesn't have coverage, how do you help the provider and the patient get the coverage? And so literally, I'm working on a single button. It's called the medical home button. And It will look at the patient, look where they live, look at their insurance coverage. I can't really do managed care, but that's beyond my ability with referrals. That has to come from that primary. But giving the physician at the bedside, I don't have to think about what zip code they live in. They're gonna click the medical home button.
Hmm.
And if they have a primary care, it's going to send them back to the primary care, because I do have a strong feeling that patients leaving the emergency department should always be going back to the medical home, even if I need them to see other subspecialists. And so the corollary to that is making sure that the provider next to the medical home has the ability to communicate directly to the office of whatever subspecialist they're trying to do. Now, as Epic evolves and as other healthcare systems get on Epic, it'll be even easier to help communicate this between the different uh, versions of Epic.
Right, right. Very good. As you were, we're talking about cognitive load, and that's, as I think more about it and some of the things you've discussed, you know, that's why we don't want to use the nuclear option, because customization is an attempt by the individual provider to reduce their cognitive load by getting the note to work well for them. And we all have ways that we like to see information. It could be fonts. It could be a chart versus a graph versus something visual. We're all different. You know it when you see it, that old
Yep.
expression. I know a good layout of information for me when I see it. The more I can make information on a screen or on paper, and sometimes those things vary. Sometimes you want a combination of those things. It's fascinating to know that everyone's brain works differently. We all consume information differently. We want to see it a certain way, and then it works for us. A
Mhm.
report, you could take a report that's got a lot of different elements to it, and you could take 20 executives and you could say, just create this report the way you want to see it. And they'd all be different. Everyone would be different colors and charts, and everything would be different. Some people would want more data, some would less. So that's where the personalization comes in, and that's why people went rogue, is because they want to see it the way we want to see it. It works for them. The nuclear option would take that away from them. You don't want to do that. So this cognitive load thing is very interesting. We want to be sensitive, but if we're oversensitive, the price is too big on the back end. So this is not a cut and dry black and white. This is nuance. This is leadership. This is meetings. This is one-on-one discussions. Am I correct? Tell me your
Oh no.
thoughts.
So I was working last night, and I was going over a case with one of the providers I was working with, and we were going over the labs. I go vertical, she goes horizontal. She showed me the horizontal. I'm like, you gotta go vertical.
Oh, that's perfect. That's hysterical.
And I'm like, that's just not the view I'm used to.
That's it.
You think back to the number of providers when we switched the electronic health record who were begging for the fishbone of the CBC, right?
Uh-huh.
And you know, it probably, and many facilities have mocked up the old fishbone back from when we used to do paper charts. And it's always interesting when you have a downtime,
Yeah.
planned or unplanned, and you have to go to paper. We
Right.
had an unscheduled downtime recently, and I was working, and I was working with some of my younger providers. And I said, "Okay, guys, we have to go to downtime procedures." I handed them the paper, and they said, "We don't know how to do this. We don't want to do this." I mean, the reality is a lot of physicians have grown up at this point on the electronic health record.
Right.
Most of my residents probably do not know how to write a prescription, right? And
Right.
God forbid you try to get someone to write down the orders for anything complex like a patient in diabetic ketoacidosis. Now we do
Oh,
downtime procedures, and those we established, and everyone did well. It was fabulous few hours, and I was really appreciative of how my staff stood up.
Uh-huh.
But I will always laugh at the, I don't know how to do this.
Yeah.
I don't want to do this.
Yeah.
So, um, the cognitive load is growing exponentially. We know this is just part of medicine.
Right.
It's its own version of Moore's law.
Yeah.
And we are being held more and more responsible for the entire electronic health record, right?
Yeah.
And so our ability to use the informatics and AI will be helpful in some of this, but it is where we can save the cognitive load, where we can help the providers, and where we can also drive quality and safety for the patient is, it's the Goldilocks approach, right?
Yep. Yep.
And it's really fun
Yeah.
when things work really well and when things are integrated and providers are like, that's amazing. And that's constant feedback, talking, listening to pain points, knowing what priorities are. And there are a lot of conversations. When I'm working in my department clinically, I feel like I'm a first grade teacher and everyone's coming to the teacher for help
Mm-hmm.
or ideas.
Right. All right. I don't want to keep you too much longer, but I do want to touch on this sounds like you do some cool stuff yourself, some cool builds. Just take us through explaining, so people were going rogue and you came up with the idea that, all right, there are certain areas we need to get you back to foundation, so to speak,
Right.
or we need to get you back in line. There's certain data I need, meaning there's certain customizations we have to pull back, and that you have to do, and you're going to get pinged, or you got pinged, Dr. Weiss. You got pinged when they weren't doing certain things in their note. Perhaps you could explain to me. I don't know if it was they got pinged or you got pinged and could reach out to them, trying to get them to get the note in the shape you wanted to pull back on those customizations. Tell me, is that something you built yourself? That alert system? Did the
Yeah.
alerts
No,
go to
no,
them or did it go to you?
I I do everything actually. There are certain alerts that I send to the provider. There are
Mm-hmm.
certain alerts that I will send to quality. Violent restraints of the patient, very specific documentation associated with that. They have redundancies in driving the provider to the documentation. Well, herding cats is not the easiest thing in the world.
Right.
And so we have a quarterly meeting, and every quarter they would talk about the fallouts. So I decided, well, I don't want to know about the fallouts a quarter later.
Right.
So now it's automatically sent to my quality people to review in real time. Same idea with sepsis alerts and command senders, et cetera, is getting the information over to another pair of eyes. The rogue note was very simple. There are certain pieces of the electronic health record and our documentation that you need to have in there. And so you bring all the information into the appropriate area, and everyone has their own documentation. You can talk about APSO notes. Obviously, ER notes are more complete from beginning to end, histories and physicals, and you identify the area in the note that you need to have the data, and then you integrate that with links, and then you tie alerts to the links if they're not there.
Why do they still have the ability not to put that information in? So you're saying if they don't do it the way you want them to do it, an alert is sent out for them to do it. Why aren't they just not able, like sometimes you have a form online and you're trying to
Yeah.
submit it, it says you haven't filled in this field, doesn't let you submit it. Why not do it that way?
Well, just in general, hard, absolute stops in the
Yeah,
electronic health record is an exceptionally challenging workflow to really hardwire
right,
because of all the downstream effects,
right.
right? Um, med reconciliation on discharge. Well, now patients start stacking up in the hospital, right? Um, and so true hard stops
Yeah.
are really frowned upon. But prompting them in a natural workflow. So water goes downstream, right? So I'm doing my note. Oh, I restrain the patient. Into my note comes the restraint documentation. And I can't sign my note until I've done the restraint documentation. It's following their workflow and makes it natural for them.
But that sounds like a hard stop.
Um, you know, and I'm not sure how much of the clinical documentation you've looked at, like,
Not much.
um, you know, in your notes, you have different fields to fill out.
Hmm.
But if the field doesn't exist, you can't fill it out. So then you're left with, okay, you restrained the patient, please put in dot restraint. Or you bring it in for them. You bring it in for them, it meets the compliance, it works in their workflow,
Hmm.
and they're not getting annoyed with me at the end of the quarter on their fallouts.
Right. You're right. You're helping them do it in their workflow as opposed to
So
after the fact.
is it an absolute hard stop? Well, there are ways of erasing it. You really have to literally erase it.
You have anyone who's done that?
Um, well, I run about 85-90% on the hard score, so
Uh-huh.
10% are erasing it.
So you've got, and this is kind of funny. You're trying to herd cats sometimes, as we said. Now, some of those cats are really difficult, right? Some of them, I wonder if it seems like some of them are just wake up in the morning figuring out how to get outside of what you're trying to make them do.
I was told that I was impeding on their civil liberties.
So it's a constitutional issue.
It was a constitutional issue. Um,
Were they serious?
well, they didn't. I wasn't. Who handles constitutional civil rights? Department of Homeland Security hasn't
Right.
called me.
They haven't called you yet.
So
Yeah.
no one's called me on that one. I think within the different build,
Yeah.
and when you're trying to lead forward what could be 40, 500, 4,000 providers,
Yeah.
you want to listen.
Yeah.
And sometimes my role is to say no.
Yeah. You have to have gravitas to be able to say no to some of these folks.
And I have these conversations with my leadership,
Hmm.
right? Okay, this is a concept, this is an idea. I think we should go forward. Or, this isn't going to work well.
Hmm.
And I love this guy to death, but I'm going to impede on his civil rights.
Right.
And by the way, at the end of the quarter, if he decides to erase it, then the compliance people are on him,
Uh-huh.
right?
Right.
And so there is so much clinical documentation that is required for different reasons within the patient encounter
Right.
between nursing, physicians, or other ancillary services. Helping them do it is really one of the biggest roles of the informaticist because it makes their clinical lives easier.
Hmm.
And depending on how you use the data, it helps the patient as well. And so that's the biggest role as an informaticist.
All right, Dr. Weiss, I'm going to ask you one final question and let you go. This has been a lot of fun. I've really enjoyed it. This is usually how I frame it up. Your best piece of advice to someone in your position at a comparably sized health system. So you, maybe with 3, 4, 5 less years of experience, what's your best piece of advice to that person?
I'll go 3, 5, 15,
How about
right?
15?
Um, as you develop your electronic health record, plan for the future.
Mm,
Make sure you have the skeletons to work with whatever electronic health vendor you're working with. And so you have the backbones for when these problems occur
Mm-hmm.
and plan it from the beginning.
Right.
As you grow and develop, plan for 5 years from now. So
Mm-hmm.
you may be making changes today, but think about what you're going to want to do 5 years
Right.
because you want to make sure you have the skeleton and the bones to optimize, but you also want to make sure that you're efficient with it. And there are pieces that I wish I had installed 15 years ago that would make my life so much easier today.
Yeah.
And one of my former colleagues listened to me on one of his most recent go lives.
Uh,
And he's like, we're putting this there. I don't know if we're going to need it. I don't know when we're going to need it, but make sure you have those anchors to drive the workflows and have it planned for the future. So for today, tomorrow, and next year.
because because refueling isn't fun.
And along with that, vodka works well. Um, and a sense of humor goes a really
Yes, it
long
does.
way,
Yeah.
both with the providers, your analysts,
Yeah.
your administrative team. But listen, listen to what they're trying to do and try to do what's best for the patient, the providers, and understand where the providers are going to be making mistakes or where the patients need help and help them succeed.
Brilliant, Dr. Weiss. This has been a blast, a lot of fun, and
Anthony, thank
I
you.
learned a lot. And I hope we can catch up with you again down the road for something else we're working on.
Absolutely. I'm working on another very interesting project associated with child abuse.
Oh,
So,
excellent, excellent.
so
Well,
well,
I'll
I'm like,
hopefully we can catch up on that down the road. Thank
absolutely.
you so much. Have a great day, Dr.
Have
Weiss.
a great day.